President of IAPS, Dr. Sumitra Kumar Biswas, and the Secretary General, Dr. Vikesh Agarwal, Dr. Manjusha, for this very innovative NextGen series of lectures. Actually, I have not been in touch with whatever is happening in IAPS because I've spent more than 35 years looking after various aspects of IAPS, and I thought it's time to take a break. But this is a very good idea because this particular topic, so many people have been asking me to discuss. I'm talking of postgraduates from in pediatric nephrology, urology postgraduates, and pediatricians, both consultants and pediatric PGs. And in fact, I sort of, troubled Vikesh and said, can I give the details of this to all these people to join, including an overseas group from University Malaya. So this topic is a great topic, a very important topic. And the reason why we can cover it comprehensively is because you have given us 40 minutes to do it. And I hope to do it. And basically my style of presentation or talking is based on my own experience. I'm not as academic as, Dr. Ramesh Babu, with the publications and things like that. But whatever I'm talking comes straight from the heart and whatever I have seen over a period of time. So what I'm going to tell you is I'm going to give you a very practical approach to the management of neurogenic bladder. And I hope it will be helpful for you. I want you to look at everything in pediatric surgery or pediatric urology as it is being presented and spoken upon, not only as a means to passing an examination, but as a life lesson. And that's extremely important for you to keep in mind. So the definition in the outline of the talk is a neurogenic bladder essentially is something that cannot store urine at low pressures, nor can it empty completely. That is the best definition of neurogenic bladder that you can find. The recommendations in this talk are based on European Association of Urology, the European Society of Pediatric Urology guidelines published in Neurourology and Neurodynamics in 2019, and also the chapter that we have written for successive editions of Dr. Namalwar's textbook of pediatric nephrology. So we have sort of, taken from all this and put it together. So the causes, as you well know, the commonest cause of a neurogenic bladder, it's a no-brainer. It's essentially a spinal cord defect, a myelomeningocele, or all the variants of the myelomeningocele that come. I get very confused when people talk about all sorts of things like myelocystocele and intradural lipoma and split cord malformation and all that. Basically, I've lumped everything together into a myelomeningocele. And then sacral defects. Don't forget that partial or complete sacral agenesis also can result in neurogenic bladder dysfunction. The third thing, very important, is any pelvic surgery in a child. It's very unfortunate that surgeries for anorectal anomalies or pull-through for Hirschsprung's disease or even surgeries for cloaca, all of them result in some sort of neurogenic damage to the bladder. This is something, though we try to stay, I hope you all remember the dictum that you have to stay strictly in the midline behind the bladder and also behind the rectum. And but in spite of that, in all these conditions, when you do surgery, particularly when you do an anorectal anomaly, a PSARP, the chances are it is going to result in a neurogenic bladder. Surprisingly, even very low anomalies, for instance, one of the commonest causes of neurogenic bladder that we have seen have been rectovestibular fistulas. And you would think that a low anomaly will not cause a problem, but the dissection that is involved in bringing the anorectum down to its normal place within the sphincter in some way creates a situation where you get a neurogenic bladder. Now, the reason why I'm saying this is in days to come, you're going to find this is going to be of great medical legal importance, because time and again, what people have told us is once we finish the consultation, they say, but doctor, before the surgery,
please, everyone mute yourself if you're a participant.
Before the surgery, the child was voiding completely. I'm saying this because of practical experience, so it's extremely important. The same thing applies to myelomeningocele as well. What I'm asking people nowadays to do is to do an MCU and also, if possible, a video urodynamics, but we'll come to it a little later. Conditions with bladder outlet obstruction like posterior urethral valves, ectopic ureteroceles, voiding dysfunction that is refractory, not treated, can all result in a neurogenic bladder. Please remember, PUV in that context is extremely dangerous and something that you have to remember and keep in mind. Ectopic ureteroceles, especially in female children, they're particularly large, those that come right up to the bladder outlet and prolapse into the urethra that distort the trigone, are all conditions that can result in neurogenic bladder. Traumatic and neoplastic spinal conditions, you don't have to, don't really need to wonder that it results in a neurogenic bladder, or any occult spinal condition which tethers the cord during growth. Special conditions are conditions where there is no overt neurological cause, but the bladder is behaving like a neurogenic bladder, what's called the non-neurogenic bladder, otherwise synonymously called the Hinman syndrome. The Ochoa syndrome is a variant of that. We have seen 2 Ochoa syndrome in all these years, and these are children who have a frank neurogenic bladder, a non-neurogenic neurogenic bladder, but when they smile, it is unmistakably a grimace. It is also seen in children with cerebral palsy and all sorts of the variants that you get from that. The treatment for these conditions also is the same as neurogenic bladder disease. Now, when it comes to symptoms, the presentation is almost uniform in everyone. The presentation is you have very anxious parents. Generally, they are accompanied by grandparents who say, my child has no control. The child has wetting, has urinary incontinence. Usually, there is a history of recurrent UTIs, which may be febrile or afebrile. And generally, there'll be encopresis, which is soiling of stool. The outcome of neurogenic bladder, why neurogenic bladder is such a fearful condition, is that neurogenic bladder results untreated, results in severe renal scarring and in chronic kidney disease, and in a lot of cases can result in end-stage kidney disease also. So the fundamental cause, again, I'm reinforcing to all of you, sustained high pressures in the bladder, which impede renal filtration function. And it's very important to remember that early treatment is paramount. In the history and investigations, the first thing that you do is you review the antenatal records to see if something has been documented antenatally. I'm often called to speak on in the obstetric and also in sonology meetings where antenatal diagnosis is being talked about. And in one of the meetings recently, which happened in the Chennai Trade Center, which was organized by Mediscan, they were showing pictures of ureteroceles. And the general impression that they had was, ureterocele is just like a small balloon, you pop it and everything becomes all right. And I said ureteroceles are very dangerous, especially duplex systems with large ureteroceles subtending the upper moiety can result in huge bladder-based defects and can result in a neurogenic bladder. It's important to look at antenatal records quite carefully and document it. Again, lower urinary tract symptoms. Please look at lower urinary tract symptoms. Find out when it first happened. Things like frequency, urgency, wetting, stooling. What are the habits with stooling? Does the child sit to stool? What are the stool timings? UTI and enuresis. The general emphasis among parents is only about enuresis. They talk about enuresis because that bothers them. The rest of the things, they may not be very clear unless you have a sort of a format on which you go through the entire thing step by step and document it. The bladder bowel diary, thanks to all the international, the ICCS documents that have come out repeatedly. I think it first started in 2006. There have been 3 ICCS big documents, and the bladder and bowel diary is something that has become commonplace for everyone, both in pediatric surgery and also in pediatric nephrology. The bladder bowel diary, though important, is only a pointer to something that is going on. You really can't expect somebody to be very accurate with regard to the volumes voided, the volume of leak, and all that. It gives you a rough idea. If somebody says my child is voiding very frequently, and you see 20, 25 entries in the bladder diary, then you know they have an issue. Okay, motor and mental milestones. Remember, we spoke about children with the developmental delay, including the ubiquitous ADHD. So it is important to document all that, because tomorrow, sometimes in children with cerebral palsy or in children with ADHD or other disorders that are very hard to sort of, bring under the ambit of a specific diagnosis, sometimes wetting and other lower urinary tract symptoms are very hard to bring under control. On the clinical examination, very important, as the child is walking in, look at the gait, look at the posture. You can very briefly look at the power and tone in all the major muscles. You don't really have to look at reflexes, but remember, looking at the back, looking at the anus, looking at the gluteal cleft. Is the gluteal cleft deep? The normal anus, you have to separate the cheeks in order to be able to look at the anus. The anus should be tightly closed. And when you attempt to open the anus should again respond by closing. You should not be able to see the anal mucosa protruding outside, or the entire anus should not be visible to you. Palpability, expressibility of the bladder, fecal loading. Make it a habit in every case to look for a palpable sigmoid. Over a period of time, you'll become very good at it. Sometimes a sigmoid that is so loaded will be palpable on the right lower quadrant also. If it's a small baby, look at the head, measure the size, fontanelles, sutures, and whether there are any dysmorphic features which point to something very abnormal. Among the investigations, the most important investigation, the ubiquitous investigation, is of course a renal bladder ultrasound, where you look at kidney sizes, parenchymal thickness, pelvis and ureteric dilatation, bladder wall thickness, post-void residue. Please mention all this. Remember, bladder wall thickness for all the postgraduates. Remember, you have to know whether the bladder is full or whether the bladder is empty, because the relevant sizes, the relevant millimeter thickness varies in its importance, whether it's full or empty. On the micturating cystourethrogram, I don't have to teach all of you. You must be experts in diagnosing a neurogenic bladder. The shape of the bladder, the presence of trabeculations, the presence of saculations. Saculations are small mucosal outpouchings that are seen in the bladder. The bladder neck, how does the bladder neck look? Is it hypertrophic? Is the bladder neck hypertrophic? Is the bladder neck normal? What is the posterior urethra like? Is there VUR? Is there presence or absence of VUR? We have often seen when you have a postgraduate and you show them an MCU, the first thing that strikes them is the presence of reflux. I would suggest that you start from below and go upwards. Look at the urethra, look at the bladder neck, look at the bladder. Then you look at the VUR, because it's very hard to miss the VUR. The presence or absence of post-void residue on the plain film, especially either the pre-study film or the post-void film, make it a point to look for sacral anomalies. The DMSA renal scan, look for renal sizes, scars, function of the kidney. Non-invasive urodynamics is Uroflow and Uroflow EMG. A Uroflow EMG is where you put electrodes in the perineum to document perineal activity as the child is voiding. I think you had a NextGen lecture by Ramesh Babu on urodynamics, and I'm sure he would have covered all this. And of course, video urodynamics, about which I'm going to talk to you in great detail now. So, the management guidelines are essentially very simple. I'm sorry I had to put this together very quickly. I know I've already seen two spelling mistakes in my slides. Please sort of, forgive me for that. How do I protect the kidneys from damage? Remember, all the kidneys are normal at birth. So that should be paramount in your mind. The second thing is, how do I prevent UTIs? How do I provide dryness? How do I lessen wetting? So when you look at it from a parental perspective, it is the wetting and the dryness that is more important. It is up to us as experts in children's surgery to tell the parents that your aim is to protect the kidneys from damage and also to protect against UTIs and to prevent UTIs. So what is the armamentarium that we have with us? Clean intermittent catheterization forms the cornerstone of management of neurogenic bladder, both during the daytime and also nighttime continuous drainage. Then drugs also are supplementary anticholinergics, alpha blockers. Then we have newer therapies like botulinum toxin injection, and of course the age-old surgical techniques to expand the bladder, all of which we will go into in a very short while. So just to give you a few pictures of what neurogenic bladder looks like, here is a neurogenic bladder, you can't miss it. It's sort of, like a fir tree going to one side. You can see the trabeculations in it. This is a bladder that shows not only trabeculations, but also saculations. Where I'm pointing are the sacules, the mucosal outpouchings, which indicate very high bladder pressures, the presence of massive reflux, the also intrarenal reflux is happening in this kidney. This is what I was telling you about bladder neck hypertrophy, the sort of ledge that you see posteriorly and also the notch that you see anteriorly is bladder neck hypertrophy. A small paraureteric diverticulum here, the bladder looking abnormal in shape. Again, you can see in this particular case, it's a trabeculated bladder with trabeculations and saculations. The bladder neck is normal, but you can see how it comes to a point at the external sphincter. And this is the spinning top urethra that we keep talking about. The spinning top urethra is a condition where there is no correlation between the detrusor contraction and the external sphincter relaxation. In a neurogenic bladder, this means that this sphincter is denervated. When you see that, it's a denervated sphincter. Forms a fixed outlet resistance. Now, again, here is a condition where you have a trabeculated, saculated bladder. The bladder neck is normal. You can see a dilated posterior urethra. Then you can see a bulbar dilatation of the urethra and then a good stream with urine pooling in the prepuce, bilateral ureteric reflux. So I want you to focus on all this first before you talk about the VUR. Very important. Just a few pictures of DMSAs that are abnormal. Here is a wedge-shaped scar. I've taken this from the chapter that we contributed to Dr. Nammalbar's textbook. Here, there are defects at the upper pole of both the kidneys. And very subtly also, there is poor uptake at the lower pole of both the kidneys also, which may indicate ongoing renal damage. Here again is a scar in the left kidney in the upper pole. There is parenchymal loss. And here again, almost an entire pole has been completely lost on the right side. So this is renal scarring. It's important to look at the DMSA in the left posterior oblique, in the right posterior oblique, so that you can look at the entire kidney in all aspects. So the management of neurogenic bladder essentially comes down to the most important aspect of neurogenic bladder management is from the newborn period. And it's very important wherever you are practicing, wherever you live, please talk to the neurosurgeons and say neurogenic bladder management should be started at the newborn period. So previously, actually, when I did the European board exam in Leuven, Belgium, where the question was, should it be watchful waiting or should it be proactive? And we had to discuss the pros and cons. Today, there is absolutely no doubt that it has to be proactive. Why it has to be proactive, I will show you. But if you are asked this question in your exam, you say the EAU, ESPU guidelines in 2019 have said that the DMSA is normal at birth, but it's in 46%, it develops scars if proactive approach is not used. So that sort of seals the argument that proactive approach is the best way to manage a neurogenic bladder. Extremely important. So the myelomeningeal seal has been closed in the newborn. What next? What we generally do is we leave a bladder catheter for about 3 weeks till the back heals. Then we start CIC and start antibiotics. We start bowel management. At 3 months, we do a renal bladder ultrasound, a serum creatinine, a urine analysis. Then we would do a micturating cystourethrogram, a video urodynamics. All this is variable. This is variable. It all depends on what the renal bladder ultrasound says. Suppose the renal bladder ultrasound says that the kidneys, that the bladder is emptying effectively, there is no residual urine. And remember, in one void in an infant, you cannot identify this. Only 1 in 3 or 4 voids in an infant is complete. So you might have to do an ultrasound at various periods of time in order to come to that sort of a conclusion. If the child is infection-free, if the child can empty completely, maybe you can even delay an MCUG or a video urodynamics. Video urodynamics in infancy is particularly difficult. It is not something that I would recommend to you when you start off. If you feel that the bladder is hostile, you can start oxybutynin. Generally, we don't start oxybutynin immediately. We keep a very, very close watch every 3 months, as I said, on the renal bladder ultrasound, look at the creatinine, look at urine analysis. And then if the bladder wall thickness is still very high, then we would start on oxybutynin and keep on antibiotics if PUR is present. That's again something that I don't have to tell you. If it's a male child, I would also circumcise the child in order to protect against urinary tract infection. So that's what we would do. Now, at 6 months, again, I would repeat a renal bladder ultrasound, a serum creatinine, a urine analysis. This time I would do a DMSA. If I have done a VUDS, see, all these I'm telling you are the European Society guidelines, which says the first urodynamic study has to be done within the first 3-month period as soon as the bag is closed. The second one should be at 6 months. If the bladder is hostile in the earlier study, then you would repeat it. At 9 months, you would do a urine analysis, a renal bladder ultrasound. At 1 year, you would do a renal bladder ultrasound, a micturating cystourethrogram. If there is no VUR, you would stop the antibiotics. You continue to monitor the urine by doing dipsticks at home. If VUR is present, or if there is a febrile UTI at 1 year, you would do a video urodynamic study. And please remember, in all this, right at the beginning, you have started this child on clean intermittent catheterization. Now, the question that is asked is, how often should you do clean intermittent catheterization in a newborn or in an infant after back closure? And the answer is at least 4 times a day, not once a day, at least 4 times a day. Now, there are very good reasons as to why this is useful. When you do that, the most important thing is the child gets used to a catheter. And tomorrow, if you have to do clean intermittent catheterization, the child is not fearful. The caregivers are also well adjusted. Because if you suddenly start clean intermittent catheterization at a later age, you find a huge amount of resistance from the child and from the parents. So till 2.5 years, you would do a renal bladder ultrasound, a serum creatinine every 6 months. You would adjust the oxybutynin dose if you have started the oxybutynin. I think there's a lot of controversy with regard to oxybutynin usage in neurogenic bladders. There are lots of people. I know people like Sudipta Sen, he's a master in neurogenic bladder, would start oxybutynin very early. Oxybutynin, sometimes what will happen is, oxybutynin will be very effective in an infant and will contribute to post-void residue and will also create constipation. So you have to keep adjusting the dosage and keep a watch on it. If your patient is close by and they come for regular follow-up, you can start them on oxybutynin, no doubt about it. Repeat a cystometrogram or a video UDS if there are new symptoms. Keep a watch on the bowel. Follow the same protocol till 5 years of age. Thereafter, follow up yearly till puberty. So between 5 years till puberty, you would do DMSA at 5 years, at 10 years, at 15 years of age. At yearly follow-up, you would do blood pressure evaluation, urine analysis, renal bladder ultrasound, serum creatinine, and the newer markers like cystatin. I don't have much exposure to cystatin usage, so I may not be qualified to talk about it. I'm just saying it for completion. Again, we would adjust the oxybutynin dosage, and CMG, VUDS, repeat earlier if there are new symptoms, UTI, new onset renal scarring. So the trigger factors for doing a video urodynamics or a cystometrogram would be if the child has, say, a breakthrough febrile UTI. You have the child on antibiotics. Remember, the Indian Society of Pediatric Nephrology, especially in this sort of condition, would recommend that you continue antibiotics even till 5 years. If you have circumcised them and if they are infection-free, you can stop and see how they do, especially if they have no reflux. But if they have reflux, it may be worthwhile to keep them on antibiotics. A lot of these things are a little gray. I'm just putting out the gray things for you, but there are some things that you have to remember, which is follow up within the first year. Follow them up every 3 months. From 1 year till 5 years, you have to follow them up every 6 months. Beyond 5 years, you would follow them up every year. So that's the sort of protocol that you would have. What sort of investigations you would do, I have outlined. When you would intervene to do special investigations also, I have told you. So, after spine surgery in spina bifida, the aim, as I said before, is to maintain a low pressure bladder and to preserve the kidneys. The important thing for all of you to remember is that the level of the lesion cannot reliably predict bladder bowel involvement, mainly because myelomeningocele is a complex condition. Also, when you're doing surgery, unless you're using intraoperative nerve monitoring, and you're extremely careful not to injure anything, you cannot really decide how many nerves are affected or how many on which side. The only study that can answer the following questions is video urodynamics. And the questions that we ask, which video urodynamics answers are, at what pressure is urine stored? Are these pressures low? So that is called compliance. Is the bladder stable or is the bladder irritable? That is overactivity. In a neurogenic bladder, that would be called neurogenic detrusor overactivity or NDO, as opposed to overactivity in general, which is called idiopathic overactivity. Is there reflux? If so, what grade? On which side? When during filling? Is it during filling or is it during voiding? Is there urine leak as the study is going on? If it happens, when does it happen? At what pressure does it happen? So this is called leak point pressure. So does the bladder empty effectively? What is the residue? In other words, if you look at the red words here, we look at compliance, overactivity, reflux, leak point pressure, residue. And then finally, the question is, if the bladder is abnormal, what can I do in order to stabilize function? The traditional characterization of bladders in video urodynamic study, I'm just mentioning this as a point of completion. You have to remember this, particularly when you're taking the exam, you might be asked this. Whenever you have an overactive sphincter, either with an overactive detrusor or with an underactive detrusor, you're having increased outlet resistance. Increased outlet resistance means dangerous pressures within the bladder. On the other hand, if you have an underactive sphincter, irrespective of whether the bladder detrusor is overactive or underactive, it is safe because the bladder leaks. So essentially, you have 4 conditions. You have 2 conditions where there is an overactive sphincter with an overactive or an underactive detrusor. You have 2 conditions where there is an underactive sphincter with either an overactive or an underactive detrusor. Remember, whenever you have increased outlet resistance in the form of an overactive sphincter, that's a dangerous bladder. You have to remember that. So we come to the first of the questions that we are going to answer. I already spoke about this earlier. In a neurogenic bladder, clean intermittent catheterization, should it be early or should it be late? I told you this debate has already been sorted out in the sense that early CIC is what is recommended. What are the advantages? It empties the bladder adequately. It avoids residue, the risk of UTI. It avoids high pressure reflux and renal damage. It keeps the child dry. The early introduction of CIC is strongly advocated. In South Asia, caregivers are very reluctant to start CIC. A lot of times, what we do is, when we advise the starting of CIC, at the first visit, the main complaint to the parents, they will maintain a bladder diary and say, we have followed whatever you have said, but these are the number of times that I put a catheter and I haven't got any residue. My answer to that situation is, believe me, continue, it will benefit your child. And I'll show you examples of why it is important. So between January 2023 and January 2025, in a 2-year period, we did 104 video urodynamic studies. 30% were on spina bifida. So surprisingly, what we found is 70% of those who had the video urodynamic study for spina bifida were not on CIC. Therefore, all of you, my dear friends, ladies and gentlemen, your task is cut out for the next 5 to 10 years. I will retire within that period of time. You have to ensure that all the spina bifidas that you see or the neurogenic bladders that you see are started on CIC right at the time of birth and continued thereafter. Now, we're going to see a few examples where I'm going to reinforce this idea to you in a very clear manner, so you have no doubt that that is the way to go. Here is an example. A child, spinal lipoma, operated at 6 months of age, has been on regular CIC since then, 4 times during the day and on nighttime drainage. The child is on tolterodine with an anticholinergic, aperients to sort out the bowel. Had VUR on the right side 2 years ago, 1 episode of febrile UTI, had a polar scar when they did a DMSA at 15 years of age. So the child came at 15 years of age for a video urodynamic study. Okay, remember, from 6 months of age, the child has been on regular CIC, which means for 14.5 years, a child has been on CIC. Here is the urodynamic study. Just very briefly, I know Ramesh Babu would have already explained it to you. In this graph, this is the PVES, this is the P abdomen. When you subtract the P abdomen from the PVES, you get the P det. So the P det is what we are looking at. Here is the volume of fill. And in this particular case, we have filled the bladder up to 400 ml. The bladder has got stable end filling pressure. This is end filling pressure. You can see on the side here, the markings are 0 to 50. That is what we do when we do pediatric urodynamics. So the pressures are pretty low. And then more importantly, we take intermittent pictures. In a video urodynamics, we would take intermittent pictures using the C-arm. You can see the bladder definitely looks neurogenic. There is no doubt about it at all. And you will find that the bladder can be emptied completely by catheterization later. There is no reflux. So what is the benefit of 14.5 years of CIC? That the kidneys are fairly preserved. There is 1 scar on the DMSA, a small polar scar, but otherwise the bladder is completely all right. And your work as a pediatric surgeon or a pediatric urologist has actually been done. This is what we aim for. Okay. Now, we will come to another scenario. This is a person that we saw from Sri Lanka, and he was first seen at 18 years of age, a neurogenic bladder with dribbling and severe constipation. He was not on CIC. He had had a myelomeningocele repair done in infancy. He walked with crutches. He had excellent upper body strength. We did a video urodynamics. On the video urodynamics, you can see he has neurogenic detrusor overactivity. Can you see all these things that are going up? This is neurogenic detrusor overactivity. So this is PVES, this is P abdomen, this is P det. All the spikes that you see here are coughs. But you can see the severe neurogenic detrusor overactivity. The end filling pressure is high. Again, the recording here is 0 to 50. I'm going to do this for every video urodynamics so that you become experts in looking at a urodynamic study. And here is the volume of fill. Okay. We started treatment of constipation because he was severely constipated. We advised CIC, but being at 18 years of age, he was very reluctant to do CIC. He agreed to nighttime drainage. Okay. 1 year later, what was the bladder like? 1 year later, the neurogenic detrusor overactivity persists. But see what is happening now. The end filling pressures are now 84 centimeters of water, which is very high. Okay, anything you remember the studies by McGuire et al. Anything above 25 to 30 is very bad. You can see here on the sideline, the markings are 0 to 111. The machine automatically adjusts depending on the way the pressure rises. So this is end filling pressure of 84. Okay. He also had a leak at 66, and the leak point pressure was 66 centimeters of water. And that's a very high leak point pressure. Here are the pictures that were taken. The bladder looks neurogenic. You can see one urachal, sort of a diverticulum at the top of the dome of the bladder. So we did a maze for him, started washouts. We also did intradetrusor and sphincteric Botox 2 times. I'll come to that a little later. And then we suggested that now, because of this, you're going to lose your kidneys. You have to do CIC during the day also. And looking at this, he agreed and started doing CIC during the day with nighttime drainage. Remember, he is now 19 years old. 4 years later, okay, he's been on 5 years of CIC and nighttime drainage. What really has happened now is his leak point pressure has dropped by 50%. From 66, his leak point pressure has come to 30. His end filling pressures have halved from 84 to 40. Not a great study. There was a lot of disturbance in the machine, but you can see here, this is 0 to 72. This is P-West, P-abdomen, P-det. End filling pressures are 40. There was bilateral mild hydronephrosis now. Serum creatinine was 0.9. You can see the bladder at various stages of filling. The urachal diverticulum is becoming prominent. We are able to empty the bladder almost completely with CIC. We stopped the Dropan and started him on mirabegron S. Mirabegron solifenacin is a fixed dose combination where it's 50 milligrams of mirabegron and 5 milligrams of solifenacin. By now, they had understood the value of clean intermittent catheterization every 3 hours during the day, nighttime drainage, and mace washouts. 6 years of clean intermittent catheterization and nighttime drainage. What happens? Now he's 24 years of age. The end filling pressures, and remember here it is P-abdomen, P-det. This is P-west, P-det. The P-abdomen has gone down. Has become this column. So this is the P-det. The end filling pressure has dropped from 40 on the previous study to 9 now. And you can see here the measurement 0 to 50. Overactive bladder, overactive contractions have been completely eliminated. Leak, he doesn't leak anymore. He had bilateral mild hydronephrosis. Now he's convinced, he and his father are convinced that clean intermittent catheterization, nighttime drainage, and mace washouts have turned this boy's life around. So he's now a computer professional. He came to India, spent a couple of years in India studying, and has gone back and is very happy with whatever he is doing. So this case brings home very definitely that even if you start CIC as late as 18 years of age, you can see how the bladder responds to clean intermittent catheterization and nighttime drainage. Therefore, I'm re-emphasizing that clean intermittent catheterization and nighttime drainage are the basic requirements for the management of neurogenic bladder. Now, we also get adults who come and ask us, is CIC really lifelong in spina bifida? We had a 21-year-old female, again, a software professional, who told us very proudly that she was not doing CIC for 3 years, but her parents were insisting that they have her checked with us. So she came with wetting and dysuria. And first, she was very reluctant initially, so we just did a Euroflow for her, and this is a Euroflow. I'm sure all of you will be familiar with Euroflow after listening to Dr. Ramesh Babu. She voided 353 mils. This dip that you see here is because of the external sphincter contraction. Her peak flow was 42 mils per second. So a void of 323, a peak flow of 42. On the whole, this doesn't look bad at all. We did an ultrasound and DMSA, which was normal. I don't know what prompted me, but I said we have to do a video urodynamic study. And the lady was kind enough to allow us to do that. And now came a surprise. We filled her to 361 mils, and you can see how much of neurogenic detrusor overactivity she has. That is P-west, P-abdomen, P-det. Here it is 0 to 50. You can see the neurogenic overactivity, and her end filling pressures were 37.5.
68 people are listening.
This pressure is 50, her end filling pressure is 37.5, which is high. She had a leak point pressure of 35, which is again high. So now what we did is we insisted on nighttime drainage for her. We started her on tolterodine because it's got the convenience of a once daily dosage. We alerted our adult urology colleagues. Because she had a bladder residue, we started her on tamsulosin also. And we asked for review with Euroflow on a 3-monthly basis, mainly to look at post-void residue. So this case emphasizes the fact that clean intermittent catheterization is lifelong in spina bifida. You can't avoid it. So what is the indication for any sort of bladder surgery in spina bifida? The main indication is a non-compliant bladder. So this urodynamic shows you non-compliance. This is PVES, P abdomen, P det, and you have a steady rise in pressure, reaching from below upwards. At 149 mils, you can see the pressures are 38. And this is a definite indication for some sort of surgery, let's say augmentation, cystoplasty, or something else. So if somebody asks you what is the indication for surgery in augmentation cystoplasty, in neurogenic bladder, the answer is non-compliance. Now, augmentation cystoplasty, the indications basically have been defined as overactivity not controlled by anticholinergics or by Botox. A non-compliant bladder, an example of which I showed you. The segments used are ileum, colon, stomach. The segments are opened out and detubularized. Why should you open out and detubularize a segment at all? And here is the example. Here is the mathematical explanation for this. I'm very poor in mathematics. But what we do know is when you open out, say, a 15 centimeter bowel and reconfigure it in such a way that the diameter increases, it can hold much more volume. And here is the example. From 62.5, the volume that is being held has become 249 when we have changed the diameter of the segment. So that is the reason why you would open it out and then reconfigure it into what is called a bishop's mitre. I see nowadays that when people are doing augmentation, they just put a patch. Don't put a patch. Reconfigure it into a bishop's mitre. What do you mean by a bishop's mitre? You cut it on the anticholinergic border, then you fold it in such a way, it's hard for me to explain. When you fold it in such a way that it forms a cap, like what you would see if you look at the pictures of the Pope, the type of cap that he wears is what is called a mitre. And that's exactly the way it would look. That will hold a lot of urine and will effectively decompress the bladder. When you use the ileum, you can expect hyperchloremic metabolic acidosis because there is loss of sodium, potassium, bicarbonate, and absorption of ammonium and chloride. In the colon, you can expect increased mucus production and the problem of contractility in the colon. In the stomach, the risk of malignancy when you use a gastric segment. In fact, Minu Bajpayee, who is the great proponent of gastric augmentations, is totally undiverting all of them because of this particular issue. Now, if bowel is incorporated in the urinary tract, what do the European Association and the European Society of Pediatric Urology recommend? They recommend a periodic estimation of acid-base balance, vitamin B12 estimation, a complete blood count, calcium, phosphorus, alkaline phosphatase, check for malignancy. Cystoscopy, usually malignancy is 1 decade after the augmentation. Cystoscopy can be helpful if you can access the pouch. Cytology is useless, but biomarkers are coming up in a very big way. I know for sure that Dr. Nerli's unit in Belgaum, in the Jawaharlal Nehru Medical College, is doing a lot of work on urinary biomarkers. And so probably in the course of time, you will find that urinary biomarkers are becoming important. I know All India Institute is also doing a lot of work. Minu Bajpayee had a meeting in Delhi where a lot of his departmental members spoke on biomarkers. Also, when you incorporate bowel in the urinary tract, remember the bowel can contract. I don't know how many of you remember that in the olden days when we were doing our post-graduation, ureterocystoplasties were very popular. We were using the ureter, and because they didn't have the problem of mucus production, and we thought we were very intelligent, and then we had to go and undivert all of them. and we realized that bowel is the best. So an annual cystometrogram or a video UDS is also very important. What are the complications of ileal augmentation? Chronic metabolic acidosis, 50% of patients. Okay. Calciuria, bone demineralization, which means low calcium, low phosphorus, high alkaline phosphatase, and the treatment is calcitriol 0.5 microgram per day. You have to reduce the dwell time by doing CIC. The older the patient, adolescents, adults, very reluctant to do CIC. So this is the importance of nighttime drainage also. And bicarb supplementation, you have to aim at a bicarb of 22 to 24. We have, her name, I think, is Dr. Sudha, one of the pediatric nephrologists from Bombay who join us always in the pediatric urology meets in Goa. And she always used to make it a point to tell us that you have to treat metabolic acidosis and aim at a bicarb of around 24 milliequivalent per liter. Quite important. If you are having chronic renal failure, you have to avoid potassium citrate because the potassium can create problems for you. Check vitamin B12 levels and supplement. If the child, in spite of all this, has an altered sensorium, you have to check magnesium levels as well. Stones are a big issue with ileal augmentation because of mucus, calciuria, sutures, and staples, and the treatment is daily washouts. We must credit the unit of Dr. Sudipta Sen in CMC Vellore, where they have this very nice way in which they talk to patients with augmentation. They say, just like you brush your teeth, you have to wash out your augment every day. And that is something that all of us can benefit and remember. Then diarrhea, fat malabsorption due to decreasing circulating bile acid pool. So cholestyramine, vitamins A, D, K become important. Malignancy, COPE starting at 5 years post-augment and going on, especially 10 years post-augment. Transitional cell carcinoma. The incidence is 4.5%. You can find a lot of publications off and on which are coming about malignancy when bowel is put into the urinary tract. Perforation, there is an 8% incidence because of bowel patch ischemia. This is a deadly condition where you can lose the child very easily. Ureterointestinal stenosis, even if you use, say, a tunnel reimplant, even if you use various methods like the Bricker method, you still can get stenosis, and it's about 11% in tunnel reimplants, just for you to remember. So if there are any nephrology or other PGs who don't know about the Mitrofanoff concept, the Mitrofanoff concept is where you would take the appendix with its blood supply, plug it into the bladder, and bring it out onto the abdominal wall, generally at the umbilicus or even in the right iliac fossa. So this will grow with the child and will provide a channel for painless intermittent catheterization. So the conduit has a blood supply and grows with the child. It's needed in those with augments for complete bladder emptying, especially for children who have a sensate urethra. Don't imagine that every child with a neurogenic bladder will have no sensation in the urethra. Don't assume that at all. Or if they are so big and so fat that they are unable to access the genitalia for clean intermittent catheterization, then you would need this conduit. The Yang-Monty principle, suppose you don't have an appendix, then you take a 2.5 centimeter of small bowel, cut it either close to the mesentery or completely on the anti-mesenteric border, fold it the other way. This is what I was telling you when you are constructing the mitre also. And you will convert a channel which is 2.5 into 7 centimeters with an eccentric blood supply. You can plug this into the bladder, and this you can bring onto the abdominal wall. The only problem with the Yang-Monty channel is the Yang-Monty channel gives much more problems than the appendix in long-term follow-up. The other problem is it's very difficult to get continence by creating a tunnel because the Monty conduit is quite a big conduit. Today, a lot of incontinent conduits are becoming popular, like the ileal conduit. This is a child who had actually it's not a neurogenic bladder, it was a bladder extrophy child, where we just put a segment of ileum and brought it out here. So this can be the first step towards augmenting later. You can do that. You can do that in a neurogenic bladder also. So you're decompressing the bladder straight away, and later on you're setting up the stage for an augment later on, especially in children who have neurodevelopmental issues, who cannot do clean intermittent catheterizations. Or you can do an ileum or a colon chimney. You can do a colon conduit. a bloxam vesicostomy, a refluxing vesicostomy. Today, a Mickey button vesicostomy is becoming very popular. I borrowed this from my colleague, Dr. Sendil Ganesh. The Mickey button vesicostomy. Very recently, Dr. Roma Varik has published a paper from London speaking about button vesicostomies and their outcomes in about 29 children. The reason the Mickey button vesicostomy looks as if it is a continent vesicostomy, but I have included it in incontinent conduits because Roma mentioned that almost 30% of their button vesicostomies were leaking. So the indications are children with inability or unwilling to do CIC. You can temporize the situation with any of these. So the procedures to increase outlet resistance, these were very popular operations when we were all studying. The Young D's Ledbetter or the Pipisali procedure, slings, which are fascial slings, or you can use submucosal intestine, submucosal intestine of the sheep, artificial urinary sphincters, the AS 800. Unfortunately, there is an erosion rate of 1 in 5. Invariably, any of these techniques is combined with augmentation or a catheterizable conduit. If you do not augment, you can have upper tract deterioration in up to 50% of children, and that's very dangerous. I want you to remember, whenever you increase outlet resistance, remember the upper tract can deteriorate unless you augment these bladders. As a last resort, you can close the bladder neck, but even bladder neck closure, like what Dr. Sudipta will say, has a very high complication rate, almost 33%, mainly fistulae. So I'm going to show you an example of how an underactive sphincter can fool you. This is an 8-year-old neurogenic bladder leaking all the time, no yield on CIC, very elderly grandmother looking after the child. And she begged us, asking us, is there some way that you can control the leak? So the question that we asked ourselves is, can we put a sling? And because she's a female, we thought we could take a fascial sling from the rectus and put it around the bladder neck. You can do a transvaginal bladder sling, quite easy to do. But before we did that, we looked at the DMSA, normal kidneys on the DMSA, and we did something called provocative urodynamics. So here you can see, here are the pictures, 25 mils fill, 50 mils fill. You can see the leak and the bladder completely emptied. So this time we put a Foley catheter, blocked the outlet, and then started filling. And immediately you can see there is a right-sided reflux going all the way up. More importantly, this is the way the bladder behaved. So this is P vest, this is P abdomen, this is P dead. And you can see the rhythmic contractions of the bladder indicating irritability of the detrusor when the outlet is occluded. Therefore, whenever you decide to obstruct the outlet in whatever form, please remember provocative urodynamics are mandatory. In this particular case, we said we would give Botox and then we would consider augmentation before we either close the bladder neck or we put some sort of sling or narrowed it. Now we come to the question of botulinum toxin. We've been talking about it for so long. The indication is detrusor overactivity. The contraindication is a non-compliant bladder. The method is either intradetrusor injection or sphincter injection. And the mechanism is it paralyzes the muscle, converts the detrusor to a low pressure, large capacity reservoir. And if put in the sphincter, it relaxes the sphincter and allows emptying. There are two ways in which you can inject when you're injecting in the bladder, submucosal route or intramuscular. Between the two, the submucosal is much better because in the intramuscular injection, when you use what is called the Cook needle, I'll show you an example of that, you can have part of the product coming out. The technique is you put it in 20 to 30 sites, including the trigone. You can go up to 300 units and the dose is anywhere between 2 to 5 units per kg. It can be repeated every 6 months. There was a concern that antibodies will form, but now that concern doesn't seem to be very important. And here is a very short video, a 24-second video. And that is the Cook needle. And you can see how you're creating a submucosal bleb. Okay, that's the Cook needle that is coming in. The Cook needle is quite big and it can actually go through the detrusor and go outside the detrusor. So it is good to do. It is good to inject submucosally. Now, I will go on to the next video. This is, a lot of people have asked me, how do you do a sphincter injection in a male child? Here I'm going to show you an example. Here is the verumontanum seen surrounded by the external sphincter. We are going to inject into the sphincter. This time we use a deflux needle, which is an all-metal needle, which all of you are very familiar with. The needle is coming in at 3 o'clock, and then we raise a bleb by injecting the Botox. We don't inject, you can again see we are injecting submucosally, we are not injecting into the muscle because we don't know the thickness of the external sphincter and we don't know whether the needle will go through the sphincter and the product will be wasted within the urethral lumen. Again, needle at 12 o'clock and you can see the injection sites and it's pretty effective. So again, one more case study that I'm going to show you to explain how overactivity can be treated. This was a 7-year-old caudal regression syndrome, poor left renal function, 18%, underwent ureterostomy at 2 years of age, came with complaints of increased urinary frequency, wetting from the ureterostomy, not treated, not amenable to anticholinergics. We did try anticholinergics, but it didn't work. So we did a video urodynamic study to assess the bladder status. And you can see we did a 200 mils fill. And even at 25, you can see we fill the bladder through the ureterostomy. And that's the ideal way to do if you have a diversion, that's the ideal way to fill the bladder. At 25 mils, it started leaking via that ureterostomy. But you can also see a lot of overactivity here. And because the child had been on anticholinergics, which were not working, we decided to treat the child with Botox. 200 units of Botox were injected in 20 sites. So here is an example of the use of Botox, refractory overactive bladder. Can Botox be repeated? Here is an example of that. This is a 12-year-old child, myelomeningocele and detethering done at 3.5 years. At 7 years of age, he had deflux injected under the right ureteric orifice. He had Botox injected at 10 years for an overactive bladder. The detrusor leak point pressure was 60 centimeters. And the person who did that was a pediatric urologist from the US called Atul Thackeray. He's no more. Unfortunate, very smart, very bright person. He was on detrusitol, 2 milligrams twice a day, and Minirin in order to reduce urine production at night, on CIC 5 times, not on aperients, stooling well, serum creatinine was 0.6. The right renal function was 29%. He had a thick walled bladder with 55 ml post-void residue, and an MCU was done, which showed a small capacity bladder with a reflux on the right side. And the question that was asked of us is, why is there reflux in spite of injecting deflux under the right ureteric orifice by a very competent person? And the answer was in video urodynamics. In urodynamics, when we started the urodynamics at about 100 mils fill, he had a massive overactive contraction. You can see each of these is 50. So that's 50, that's 100, that's almost 130. That's a huge pressure rise. And the pressure rise was so much that the pump stopped. So at this particular point in time, we injected 300 units of Botox in 30 sites, and 6 months later, we repeated the urodynamics. Now, it's completely all right till about 230 mils, and then the pressure spikes start. 1.5 years later, the bladder is completely ironed out. This is the PDET study. No overactivity. We were all extremely happy. 2 years later, the pressures came back. The overactive contractions came back. And this was at 238 mils fill. We did an augmentation cholecystoplasty. I'm showing this case study to explain that today, what we would do is we would repeat the Botox every 6 months. That seems to be the latest trend in the US. Unfortunately, in our country, Botox, 100 units of Botox, I think is about 40,000. So a lot of our patients cannot afford repeated Botox injections every 6 months at 300 units. So this is just for completion. Oxybutynin, all of you are quite familiar. You can go up to 4 doses per day. You can give intravesically. I haven't tried that because I'm very worried about UTIs. Tolterodine is given as a once daily dosage. It's a dosing convenience. Today we have mirabegron, a beta agonist, which comes in 25 and 50 milligrams, very effective. And when it is combined with solifenacin, which is an M3 receptor antagonist, highly bladder selective, so you have a beta agonist combined with an alpha antagonist, it becomes a fantastic combination. That's why you have that fixed dose combination of 5 and 10 milligrams, 25 plus 5, 50 plus 10, I think, of mirabegron and solifenacin, which comes as Mirago S. Alpha blockers, we use tamsulosin 0.2 and 0.4, especially in older children. For dosage, we would be very happy with terazosin, which comes as Hytrin, 1 milligram and 2 milligram. And we have found that the combination of mirabegron and Hytrin. And Hytrin is a great combination. Mohan Abraham from Kochi has actually written a paper on the use of terazosin, and doxazocin is another drug that is very effective. And you can, all these are alpha blockers you can try. In cholinergic, essentially I told you after bladder closure, after back closure, you put a bladder catheter and you wait. During that period of time, let us say in 6 weeks, the child has got a huge residue. Around about 3 weeks onwards, we would start them on a small dose of bethanacol to start stimulating the bladder, so that when you finally take out the catheter, the child is able to void and has a small post-void residue. Finally, this is going to be the final thing that I'm going to tell you. Oftentimes, we get cases where they've had spine surgery, and then the question comes, should we do a detethering? Here is a 4-year-old female child, lumbar lipomyelomyelin repaired at 5 months of age, on CIC during the day, not on nighttime drainage. Neurosurgeon had reviewed the MRI and said detethering is warranted. However, this was not a definitive opinion. And they came to us and asking us whether video urodynamics can help guide the need for detethering. The video urodynamics, this is P-West, P-abdomen, P-det, 145 mils fill. This is a cough. Everything is completely all right. And you can see as the bladder is being filled, at 50 mils, you have a left-sided reflux, which reaches the upper tracts, which reaches the kidney at about 100 mils. But finally, when you put a catheter and drain, almost everything is drained. Therefore, based on the video urodynamics, we were not able to come to a conclusion whether detethering was warranted or not. A DMSA looks essentially normal. This is a T2 weighted image of the spine. And the reason why I'm putting this up is this particular study was viewed by 2 neurosurgeons with different opinions. One said there is dura between the fat and the cord, and therefore detethering is not warranted. Another person felt detethering is warranted. So when you're faced with a problem like this, what I understood from Boston Children's Hospital in a recent meeting in Malaysia was urethral sphincter needle EMG will be the best way to identify denervation potentials in the sphincter. If you remember a few slides ago, I spoke to you about fixed outlet resistance from a denervated sphincter. Now, as the denervation process is going on, what really happens is in a partially denervated sphincter, the way it behaves is completely different from a normal sphincter. In a normal sphincter, when you put electrodes into the external sphincter, you get a uniform hum because all the motor units are recruited. Whereas when you have partial denervation, there are some motor unit potentials that come on, some don't work. So you get a sound like a popcorn in a microwave or rain on a tin roof. And this is a definite indication that detethering is required. So in conclusion, video urodynamics is the key to the management of neurogenic bladder. Please go away with the absolutely certain thing that early commencement of CIC is ideal. Nighttime bladder drainage is optimal but very useful. There are benefits even if CIC is started later in life. I showed you an example of that. CIC is lifelong. Before bladder neck tightening, do a provocative UDS. It's mandatory. The best way to decide if detethering is required is sphincter needle EMG. I showed you an example of that. Botulinum toxin injection is very useful to control refractory overactivity, and today it has almost replaced neurogenic augmentation in the Western world. Once bowel has been incorporated in the urinary tract, lifelong follow-up is mandatory. Once again, thank you very much, and that is the end of the talk.
Thank you so much, sir. Yes,
shall I stop
thank
the
you so
sharing?
much, sir.
Yeah.
Yes, sir. Thank you so much, sir. It was actually like very different from what at least what I have understood about neurogenic bladder till now. It was very eye-opening, sir. Thank you so much. If anyone has any questions, you can just put it on the chat box so that sir can answer. Sir, all these recommendations are given by the European Society of Urology, is it? So we can
European
access it
Association
also.
of Urology and the European Society of Pediatric Urology. But
Okay,
what we need is we need to evolve our own guidelines. That's again important.
yes. So now when you teach CIC, sir, especially for in the newborn time or in the infant time, how exactly do you teach them how to do a CIC, like with the tubes, how to sterilize it at home? What is your advice?
So this again, all this comes mainly from, I keep talking about, I put various names inside because I want you to know the IAPS is a homogeneous body. There is no one person who's fantastic and all the rest are idiots. Everybody has contributed to this, to IAPS, to what it is today. Sudipta and his group at CMC have always taught us how to clean catheters. Very simple. You clean them on the outside with soap and water. On the inside, you put betadine, even dilute betadine. Most importantly, you hang them out in the sun. You put them on a clothesline with a clip so it becomes dry. The moment it becomes dry, you can use it again. And very easy to do, not a problem at all. So you can change the catheters once they become stiff. They will become stiff at the end of a month. Then you can throw it and take a new one. There's a very good turnout, but nobody seems to have any doubts. That is fair. That is fair enough. Think about it also. And any role for Botox in poorly compliant bladder? No. When the bladder is poorly compliant, Botox doesn't help. Just doesn't help. Prabhu wants to ask a question.
Sir, you can please unmute yourself and ask if you want. Dr. Prabhu.
Hello, sir. Good evening.
Good
So
evening.
wonderful talk as usual, sir.
Thanks.
I have a couple of questions. Sir, what is your experience of using Mirabegron along with your Hytrin, sir?
Yeah.
I mean, what is your experience per se?
Yeah. So what we do is, we use Mirabegron. Today we use Mirabegron in almost everyone, because Mirabegron, I feel as a beta agonist, has much better effects than oxybutynin or even tolterodine. If they have a post-void residue, let us say I'm doing a video urodynamics. At the end of the video urodynamics, we ask them to void either into the Euroflow commode or they go to the toilet and void. We come back and take one more X-ray. And if we find a significant residue, we'd also put them on terazocin, on Hydrin. And what we do important, I'm so happy you asked, Prabhu, because what we do is we give the Mirabegron at night after dinner. The terazocin we give in the morning after breakfast. And we tell them, please tell us after 2 or 3 days whether you are having any dizziness episodes. And then we sort of cut back on the terazocin because it's important to know that. But very effective, extremely effective.
Okay, sir. You do, I mean, you do increase the dose of terazocin from, like described by Dr. Mohan Abraham, like from 0.02 to, then you come up to 2 per kg.
No. I feel terazocin. I feel terazocin has been a drug that has been studied well, but I think it's a little dangerous to give. It's exactly like, see, Prabhu, it should never be carried away by 1 or 2 publications on any subject. You remember, like, for instance, like, people were talking about oxybutynin until they found out that VVSSS is very fond of saying, they become fat, stupid, and demented if you put them on oxybutynin for long periods of time. So we don't really know what it will do. But having said that, I would continue with this. Suppose it's very effective. I start them on, say, the lowest dose of terazocin, and I find that their Euroflow improves, their post-void residue halves. I'm very happy. I will continue with that. I will not increase the dosage of terazocin.
So the last question I have is, do you have any experience with this functional MRI, sir?
Not really. Not really. No, I haven't. No.
Back in SGPJ, we used to do that, sir. But I think yours is much more objective the way you have described it.
Described it.
Yeah. And sir, and the last question I have, you do it under anesthesia?
The urodynamics always done in an awake state. I mean, the long-suffering Vidya is there in the chat group, and she will tell you, we do it without anesthesia all the time. Under anesthesia, urodynamics is a complete waste of time.
Okay, needle into the perineum, sir, into the sphincter.
No, we don't. No. I just told you Boston Children's. This is something I heard in Malaysia recently. It was news to me. I would never put needles into the perineum of an awake child. The child will kill me. No. I haven't done it. This is just to complete. So there is a question on, do you practice CAC universally for all neonates operated for MMC, or are you selective in your approach? So the answer is yes, we do it all the time. Everybody, we start them on CIC. Role of antibiotics in what? Role of antibiotics in what? So and Vidya has said no anesthesia, no antibiotics, and for video urodynamics. Can you inject? There was a question whether you can inject in the trigone. I was under the impression that you can't inject in the trigone. Till recently, one of the pediatric urologists in the US corrected me and said you can inject. For instance, the last case that I showed you, where we injected 200 units of Botox, and you already remember the child had reflux into the ureterostomy on the left side. So we injected into the trigone also. So when do you decide to change or stop anticholinergics for overactive bladder? A great question. And you have to sort of fine tune it depending on how much of post-void residue you have. If you have a lot of post-void residue, make it on alternate days and see whether it will come down. Teach them double voiding. And over a period of time, I think it is good to taper it and stop it if you have a large post-void residue. Are you using mirabegron in infants? We would, depending on the type of situation that we see. Normally in infants, we would start off only with oxybutynin, because still, in spite of everything that is being said, oxybutynin, you can adjust the dosage very finely, which you can't in mirabegron, because it's a 25 milligram, and how much do you powder it and what do you do? Whereas oxybutynin you can do. Once they are used to oxybutynin and once they cross that infancy period, at less, but 1 year, then we would put them conveniently on mirabegron. Suppose it's really a bad bladder, then we wouldn't mind using mirabegron also in them.
So one more person has asked, what is the role of uroprophylaxis in children who are receiving CIC but without VUR?
Oh, the answer is we have a very strong ID unit, which strongly discourages the use of uroprophylaxis. Therefore, if the child does not have a febrile UTI, we would not start them on uroprophylaxis at all. We have countless examples of children with VUR on whom we have done CIC. They don't get UTIs if you can eliminate the residue, and we don't put them on antibiotics. If they have a UTI, that's a different matter altogether. So I just wanted to tell you that today, all of you who are doing spine surgery, please remember intraoperative neuromonitoring is extremely important. Vidya will, I don't do it, but Vidya will recollect how in our unit, we see children who are now being operated by the neurosurgeons with intraoperative neuromonitoring, and the results are really good. It's become the standard of care. Therefore, you're opening yourself to medical legal problems if you don't use intraoperative nerve monitoring. I just wanted to mention that. I think we have covered all the questions that were asked. I think, yeah, thank you. So thank you very much. Thanks, Evangeline,
Thank you, sir.
for doing a wonderful moderation. So thank you.
Thank you so much, sir, for your time today.
Pleasure. Thank you very much. Thank you. All the best, all of you. Thank you.